I'm Dr. Tim DeKlotz. I'm an otolaryngologist at MedStar Georgetown University Hospital. My patients vary. I take care of a number of disorders. My primary focus and passion is in skull-based disorders, ranging from tumors of the sinus, base of skull, and brain, as well as general sinus disorders and head and neck oncology. The disorders within the sinus and skull base are widely variable and range from tumors such as pituitary tumors to nasal and sinus cancers or benign tumors to spinal fluid leaks of defects in the base of the skull with spinal fluid dripping into the nose. Currently, we're the only center in the DC region with a dedicated endoscopic skull-based team with fellowship-trained neurosurgeon and otolaryngologist working together. The benefit of having that is the degree of experience that comes from doing specialty training in these fields. In the average practice, these are disorders that are seldom seen or never seen. I work very closely with my neurosurgical colleagues. And it's interesting, 15, 20 years ago, a lot of what we do for these was just not possible. The technology, the instrumentation was not available, and it's been advances in that and pioneers in the field that have pushed it forward that have enabled us to make this a more commonplace procedure. Typically, we're able to avoid any major incisions on the face. Typically, patients leave the hospital without any noticeable evidence that they even had surgery, and the recovery overall tends to be quicker from this. So it's that minimally invasive approach that gives us the benefit of quicker recovery for patients and overall better outcomes. I think one of the biggest rewards as a surgeon is that you can oftentimes make an immediate difference in that the tumor is all of a sudden gone, or the spinal fluid leak is no longer leaking into the nose. It's an immediate benefit that you can see and tell the patient that things are going to be okay. One of the biggest senses of fulfillment I get, or rewards, is being able to see the patients through from beginning to end when they come in, oftentimes scared, not knowing what this disorder is. Oftentimes they're rare, and that many of their other physicians did not know what they were. And to be able to guide them through that process and really at the end see them come out as kind of a new person, to realize that they're going to be okay. Endoscopic or minimally invasive skull-based surgery is the use of endoscopic equipment and technology to remove tumors or treat these disorders of the skull base in a way that avoids any facial incisions or scars, to basically an extension of what sinus surgery is, but taking it to another level. It enables us to reach areas that were potentially not reachable with traditional or open surgery, or do it in a way that's potentially safer by avoiding crossing of certain neurological or vascular structures that put the patient at risk otherwise. Endoscopic or minimally invasive skull-based surgery is a unique field in that it grew out of sinus surgery. And so for the most part, it's actually very similar to a standard sinus surgery from the patient standpoint. All surgery is done primarily through the nostrils without cuts or incisions on the face. It basically uses similar instrumentation that's been slightly specialized for these particular applications. Working through the nose and the natural corridors of the nose avoids additional dissection through other structures, such as the bone of the front of the skull, or retracting the brain, enabling us to get directly at the tumor and avoid that collateral damage of the surrounding structures. Using various components of newer technology, as well as specialized instrumentation, give us the ability to do things that we were not able to in the past. One of the important things that we use on a daily basis for these cases is something called stereotactic navigation. It acts as a GPS for our instrumentation during the surgery. We can actually literally put a pointer or an instrument within the nose, and it can tell us, are we 1, 2, 3 millimeters away from critical neurovascular structures such as the optic nerve or carotid artery. Other things such as The specialized high-definition endoscopes and high-definition monitors give us the ability to see the fine detail and small blood vessels that enable us to better preserve these structures and prevent the morbidity or complications that would go otherwise. So most people have concerns that they're going to come out of surgery looking swollen or have some disfigurement, as most of the time when they will research this on the internet or what have you, of how certain types of these tumors are treated. They're looking at how a more traditional approach was taken with these, in which case large incisions and large amount of facial swelling or edema takes place afterwards. With this, for the most part, patients walk out of the hospital without any noticeable defect or no noticeable difference. And for many of my patients, they've come back and told me that they had friends or family that said, "You look like you didn't even have surgery." One question patients have and one concern they have is packing in the nose. Traditionally with sinus surgery, nasal packing was placed and has been notoriously feared by patients. For the most part in common nasal surgery, we've actually moved away from this in general, and rarely do we put packing in the nose. In certain cases where there is a known defect, where we are creating a communication between the nose and the brain, and we need to reconstruct that, the patient will require some packing in the nose to reinforce that reconstruction. Otherwise, you risk an early failure. And so it does mean you will have packing in the nose, typically for about a week. However, it comes out relatively easily in clinic, and until we find a better way, it is a necessary portion of the procedure. One of the benefits of minimally invasive surgery is that oftentimes we're able to get patients out of the hospital quicker. And so for straightforward cases, such as pituitary tumors or spinal fluid leaks, patients can often leave the hospital after a day or two. Bigger cases, such as cancer cases, that tend to be a little bit longer and require a little bit more in terms of the dissection, those patients take probably closer to 3 or 4 days, though it is variable, some shorter, some longer. Recovery is still, in terms of the having to take it relatively easy after surgery, is still going to be there regardless. Minimally invasive surgery doesn't mean that we're doing any less. It means that our access to be able to address it is less. And so the kind of collateral damage, if you say, is less. And so from that standpoint, that portion of the recovery is quicker. However, the actual degree of where the tumor is removed or the spinal fluid leak was sealed, that still takes time to heal. And the body still requires, for the most part, patients to avoid any heavy lifting or excess straining for, ideally 3 to 4 weeks to give the body time to heal in that region. Doesn't mean you're immobile, doesn't mean you're sitting and bedridden, but basically just taking it a little bit easier. Like any surgery, pain you can't get completely away from. It tends to be relatively mild to moderate. The nasal packing, if it's required, does add a level of discomfort. It's more of a pressure. Patients are taken care of in terms of ensuring adequate pain control throughout their course, from immediately post-op to after they leave the hospital as well, and regular follow-up calls to ensure that they're not in excess pain or discomfort. Endoscopic techniques and minimally invasive techniques are a powerful instrument in order to access a number of tumors in a way that we weren't able to previously. However, sometimes surgeries do require open surgery in order to adequately address it or safely address the underlying pathology. And so, using sometimes either combination of open or endoscopic approaches is key. So who fits and who's a good candidate for endoscopic or minimally invasive techniques is somewhat variable. And again, kind of what I hinted on earlier is that it is a very tailored approach, and that while not everyone does fit into a category of that, certain types of tumors are very amenable to it, especially pituitary tumors notably. that give you, the endoscopic techniques give you much better visualization of the tumor and the surrounding anatomy to be able to avoid injury and to ensure that you're able to remove all of the tumor. Certain locations are especially amenable to this, and some of this is the complexity of the skull base and the various anatomical structures that are there, and the ability to get a magnified view and working through the natural air-filled spaces of the nose to avoid that dissection either through or through the front of the head, or lifting up the brain or retracting the brain to do so avoids the morbidity for many of these approaches and where these tumors are located. We achieve at least equal results to open procedures, but oftentimes we're finding that outcomes are better, especially in select types of tumors. Notably, we're also finding that quality of life does appear to be much significantly improved with these approaches. The long-term data is still in the works of being evaluated and critically analyzed, but it does appear that endoscopic approaches do have a significant benefit for many patients. For the most part, there isn't necessarily a known cause or etiology of what brought this about. And the guilt that sometimes patients feel for doing one thing or another, is unjustified. And so a lot of the initial counseling for patients when they come in is helping them realize that nothing they did brought this on. It's an unfortunate thing that is potentially based on a genetic component that we just don't know about yet. Sometimes just minor things such as trauma that they didn't appreciate earlier in life that is giving them more issues now. Many other factors that can come into play, but for the most part, for the most disorders and most tumors within the skull base, we don't have a strong cause and effect relationship. The unique feature about the team here at Georgetown is that we have a very trained and dedicated endoscopic skull base team that does all our cases together. So that after a certain period, you know to some degree what the other person's thinking and how they're going to react in certain situations. And it enables you to work as a cohesive team to really optimize the results of surgery. From a patient standpoint, when they first get here, some of the nice components in terms of their start to finish process is that they see each of us and we each go over the individual components of our aspects, but they're oftentimes able to hear things twice because for the most part we're doing things together simultaneously. So it reinforces what the disorder is, the process they're going to go through, the surgery, the expectations, and how recovery is going to be. The complex patients of those with sinonasal cancer or malignancy are discussed in a weekly multidisciplinary tumor board with representatives from neurosurgery, medical and radiation oncology, as well as neuroradiologists, all aiding to coordinate and optimize patient care. In terms of follow-up and what patients are to expect afterwards, it's actually somewhat similar to sinus surgery in that you typically have a little bit of crusting in the nose that does last for several weeks, just from kind of the raw surfaces that were created inside the nose. After surgery, we expect patients to use a nasal saline rinse to help, one, clean out the nose, as well as keeping the nose in a moist environment, which helps speed healing. They come back to the clinic typically at 1 week and then again at 3 weeks for cleaning out of the nose. And what that entails is basically looking in the nostrils with the cameras similar to done at surgery, however with numbing medication, and gently cleaning the nose to help aid the nose in healing during that postoperative process. My initial training started at Georgetown as a medical student and came to the field of otolaryngology a little bit late in my training, but found I loved it and decided to stay on for residency here. During residency, I realized that the area of the skull base and these disorders were a field that very much interested me. However, my exposure to them was somewhat limited. And I decided to go for additional training and advanced expertise, notably in minimally invasive and endoscopic techniques at one of the major centers in the United States. Coming back, after completing that fellowship, I decided that I wanted to be able to bring that back to Georgetown and offer it to the patients here, as well as be able to educate the residents and the trainees about this from where I'd gotten my education from. When patients are evaluating what options are available in any type of tumor, other opinions are never a bad thing. And if any physician fault you for wanting a second opinion, it's an immediate red flag that you probably need to get one. But realizing and asking and saying, is there a better way to do this? And there's no physician should ever fault a patient for wondering, is there a better way to do what you're proposing to do? And for some may be able to say confidently no. Some may be able to say I don't know. We've had a number of patients that have been offered a much larger surgery, and the patients, what we're realizing is patients are becoming more educated, and they're realizing that there are potentially other options. And even if it may not necessarily fit for them, they're asking the question, and they're coming to the table asking that question: Is this amenable in a more minimally invasive way? Sometimes no, but in many cases yes. There are certain tumors that are purely occur in children, and for many of these, or for certain ones of these, this is the preferred treatment. Most commonly in children, the reason for is that you want to avoid any disruption of the growing face and bones of the face to avoid later affecting their growth of the face and appearance. And so by going through the nose, oftentimes you can avoid that. But it is much less common in children. Our entire skull-based center as a whole is truly multidisciplinary and incorporates people from all aspects of otolaryngology, radiation oncology, neurosurgery, and that some of these cross the border of what would be approachable through the nose versus other more lateral approaches versus and going through actually the ear or behind the ear, which involve different specialty trained ENTs or otolaryngologists from that component called neurotologists. I think our center has become excellent, and we offer truly a widely comprehensive approach to these patients that we can say, even if I can't offer them the best approach through this minimally invasive approach, my colleague down the hall who can see you, later today will be able to. And to be able to offer everything in one place, I think is a truly beneficial component for a patient.